During ASCO 2021 virtual meeting, we have three important studies that was reported. CheckMate 648 assessing the role of immunotherapy in advanced squamous cell cancer of the esophagus. CheckMate 649 updated results in assessing adenocarcinoma of the esophageal adenocarcinoma. And lastly, CheckMate 577, which is the adjuvant study of nivolumab in patients with resected esophageal and esophageal junction cancers. During ASCO 2021, I presented the CheckMate 648 study. CheckMate 648 is the largest randomized controlled trial conducted to date in this particular setting, evaluating the addition of nivolumab to chemotherapy or a dual checkpoint inhibition, nivolumab plus ipilimumab versus chemotherapy alone. In this study, patients were recruited irrespective of their tumor PD-L1 expression, and patients with metastatic or advanced esophageal squamous cell carcinoma were enrolled. 970 patients were randomly allocated into three groups. Group 1 is the addition of nivolumab to chemotherapy, and the chemotherapy used in CheckMate 648 is cisplatin and 5-FU. The second group is the addition of ipilimumab to nivolumab, and our control arm is chemotherapy alone with cisplatin and 5-FU. Our primary patient population is a biomarker-defined tumor PD-L1 expression of 1% or more. The secondary endpoints would also include the all randomized patient population, and we assess both overall and progression-free survival. So in our first treatment comparison of nivolumab plus chemotherapy versus chemotherapy alone, we observed a highly statistically significant improvement in overall survival in favor of the nivolumab arm. The hazard ratio was 0.54, a 46% relative reduction in the risk of death, which translates into a more than 6 months improvement in median overall survival in favor of nivolumab. We observe also a significant overall survival benefit in our all randomized patient population, again in favor of the nivolumab arm. In terms of progression-free survival, there was significant improvement in our primary patient population with PD-L1 expression. In terms of response rates, again, we observe a higher response rate of adding nivolumab to chemotherapy. Importantly, there was a tripling of complete responses in the nivolumab arm. In our second treatment comparison, again, we observed a significant overall survival advantage of nivolumab plus ipilimumab compared to chemotherapy alone. Here, there was an early crossover of the overall survival curves, but at the latter time points, there was a wide separation in favor of nivolumab plus ipilimumab, so that there was a lot more patients with prolonged survival. We observed this both in our primary patient population of PD-L1 positive expression, as well as in all randomized patient population. Once again, response rates were higher with ipilimumab plus nivolumab in our primary patient population. With regard to safety observed in CheckMate 648, we have not seen any new safety signals in any of the three arms. So in conclusion, with the overall survival seen with both nivolumab plus chemotherapy, as well as nivolumab plus ipilimumab, each of these can now represent a potential new standard of care in the first-line therapy of our patients with advanced squamous cell carcinoma, based on the CheckMate 648 study, the largest randomized controlled trial conducted to date. CheckMate 649 is a large global study evaluating patients with adenocarcinoma of the esophagus, esophageal junction, and stomach. Patients were randomized into chemotherapy, which is oxaliplatin-based chemotherapy, or oxaliplatin-based chemotherapy plus nivolumab. Over 1,500 patients were randomized in this study. Primary results, which is in the patient population with PD-L1 expression of 5 or CPS 5 or more, has now been published. And in ASCO, what we have learned more from Professor Mola is in the patients in the all randomized population, where here we see that there was a benefit in all patients, the benefit from adding nivolumab to chemotherapy. The hazard ratio is 0.80 with a statistical significance of p-value of 0.0002. But perhaps more importantly for us to learn about is what is the relative benefit for different CPS cut levels. So benefit was certainly more seen as the PD-L1 expression become more. So that patients who have CPS 1 or more, the hazard ratio was 0.76, and patients who have CPS 5 or more, the hazard ratio was 0.70. But for patients who are PD-L1 negative, i.e. CPS 1 or less, the hazard ratio was 0.92. The same trend was also seen in both overall and progression-free survival. Interestingly though, for objective response rate, it was higher in the nivolumab arm, irrespective of the PD-L1 CPS expression. We also learned more about patient-reported outcome, where there was a delayed time to symptomatic deterioration in the nivolumab arm. So really, based on all these results, I think it really established the addition of nivolumab to chemotherapy in patients with adenocarcinoma of the esophageal primary. And I think this will now impact on the global guidelines. In CheckMate 577 study, patients with resectable squamous cell or adenocarcinoma of the esophagus or esophageal junction were randomized after they have had trimodality therapy, i.e. preoperative chemoradiation followed by surgery. And the standard after surgery is for observation. Therefore, the control arm was placebo in this study, and the experimental arm was nivolumab. And we already know from the recent publication in New England Journal of Medicine that nivolumab significantly improved the disease-free survival compared to placebo in this study, with a hazard ratio of 0.69. In ASCO this year, what we learned more is regard to the amount, the magnitude of benefits according to the PD-L1 expression. Here, they look at both tumor cell PD-L1 expression as well as PD-L1 CPS expression. So the CPS is looking at both the immune as well as the tumor cells. Here, because we are dealing with a lot of adenocarcinoma, therefore, I think the CPS expression is the more important parameters. And what we observed, probably similar to advanced disease, is that patients with higher PD-L1 expression, here they categorize it as CPS 5 or more, they did have a more pronounced benefit with nivolumab. Here, for patients who have CPS 5 or more, the hazard ratio was 0.62, whereas for patients who have a CPS less than 5, the hazard ratio was 0.89. Now, apart from disease-free survival, they also have shown us two other important secondary endpoints. The first endpoint is the distant metastasis-free survival. Here, we again observe nivolumab significantly prolong the distant metastasis-free survival, meaning that it has a systemic effect on this disease, reducing the number of distant recurrences. So in the placebo arm, there were 39% of distant metastasis seen, whereas in the nivolumab arm, it was only 29%. There was also a reduction in local regional recurrences in favor of nivolumab. The second important endpoint was progression-free survival 2. Again, there appears to be a prolonged PFS2 in favor of nivolumab. Lastly, they also shown us some quality of life data within this study. And the encouraging thing is that during the treatment, nivolumab did not impair the quality of life for patients. So really, with CheckMate 577, we can establish that after preoperative chemoradiation, when patients recover from surgery, adjuvant nivolumab should be regarded as one of the standard treatment options now for this disease. We'll really look forward to see the overall survival results from this study, because that is very important for us to know that how many patients are indeed cured with adjuvant nivolumab.